You are listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
On today's episode, Dr. Srihari Naidu and Dr. Coylewright dive into the intersection of hypertrophic cardiomyopathy and valve disease, particularly focusing on the challenges of aortic valve replacement in patients with HCM. How can clinicians better predict complications like left ventricular outflow tract obstruction following TAVR, and what strategies ensure optimal outcomes? Join Dr. Naidu and Dr. Coylewright as they explore the complexities of diagnosing and managing these overlapping conditions, the role of multidisciplinary heart teams, and the delicate balance between timely intervention and avoiding unnecessary procedures. Let's get in the thick of it. Here's Dr. Srihari Naidu and Dr. Coylewright.
So first off, Dr. Coylewright, please introduce yourself and tell us a little bit about how you came to be an expert in structural heart disease.
Well, thank you for the invitation. I'm excited about this topic. I started doing transcatheter aortic valve procedures in 2012 when I was a fellow at Mayo Clinic, and also spent a lot of time training under Dr. Nishimura in alcohol septal ablation at the same time. I wouldn't say we were talking about this particular topic back then at all, that's for sure. And I've been in practice for over 10 years and, very passionate about making sure that we optimize outcomes for our patients. And there's been an increasing focus on not just getting the valve in, but, making sure that their outcomes, particularly with regards to heart failure, are the best that they can be going forward. So I think there's a lot of overlap in this topic with regards to recognizing some of the underlying disease states. So that's about me.
Excellent. So, if you take it back around that time when you were training, I was doing this as well. And for a long time, the HCM community is very much about looking at a patient in terms of their overall lifespan. In other words, one of the faults of, I think, in interventional cardiology is we tend to look in very small aliquots of time. We want to make sure the procedure's okay, and then we look at 3 to 5 years. But the truth is, and I've come to recognize this dealing with HCM patients for a long time, is that those of us in the community, we see these as bumps in the road that we have to tackle and get them to a normal life expectancy. So it's very important to make sure we do the right thing for the patient at the right time that allows them the least amount of risk and the longest longevity and quality of life. And so when I first got involved in this, the big discussion was alcohol ablation versus surgery versus traditional medications, and when to push the envelope to move towards these therapies. And I'll tell you that the field is fairly conservative. What I just described to you is a very conservative field, which is that we're looking at the long lifespan. The first thing is to do no harm. And so there's a lot of discussion about how long to push medications before you move on to SRT. And then when you move on to SRT, people were very wary about alcohol ablation versus surgery. And part of that is, we're less worried about things we refer to than things that we do within our own department, right? So alcohol ablation being within our department versus surgery, which is sort of outsourced in a way. But now, fast forward, I think these SRTs are coming back a little bit, certainly alcohol ablation, even with mavacamten. There is a need to be able to do something acutely to gradients and to alleviate outflow tract obstruction acutely and in the short term. I got involved in this, I think when we first were doing patients at my prior hospital, we were very early adopters of TAVR. And in the first few patients, we had 3 patients with this kind of this problem. And the problem, of course, is that you have a patient that comes to you with aortic stenosis. And this patient, they go through the runway towards TAVR. And when you do that, you look for a gradient and you look for a valve that looks like it's tight. And the challenge therein is that HCM was relatively unrecognized in a lot of these patients. And so is HCM always there, or is it just a small hypertrophied ventricle that then causes obstruction? And we had 3 patients, one of whom actually died after their TAVR. And that was an eye-opener for us. And this was early 2000, like maybe 2012 or 13. And then we had one patient who had obstruction afterwards, was medically managed and did fine. And the third one, I did an alcohol ablation before the TAVR and did fine. And so for many years after that, including now, I tend to take these patients out of the TAVR queue and they send them to me and I evaluate them, optimize them, which might include an alcohol ablation, then move them to TAVR. So I wanted to hear from you because several publications have come up that are dealing with this over the years, most of which have shown that if you have hypertrophic cardiomyopathy and you have a TAVR procedure, they tend to do worse than patients who don't have hypertrophic cardiomyopathy, especially women, older patients, hypertrophied ventricles. Then they have this, what we call suicide LV, and then the management becomes tricky, especially with a fresh valve. And as you know, the hemodynamics of HCM are very difficult to manage acutely. So what's been your experience, Megan, with this disorder? Are we overblowing this? Or is it that even if it happens in a subset, since it's so dramatic, it's still so important? What are your thoughts?
I think that certainly this phenomenon of having a new or revealed or worsening LV outflow tract gradient after TAVR is exceedingly rare. And I think having you here as an expert is fantastic. But I think also the experience is probably a bit unique. And the reason why I stress that is because at times what I've seen in my practice is suicide LV has been blamed for hemodynamic compromise after TAVR that's due to something else. And so in many ways, I feel like it is a diagnosis of exclusion. There's so many more things that are common that can cause a patient to have sudden hypotension after the valve goes in that really need emergent therapy that is not necessarily fluids and beta blockade. So I do worry a little bit about stressing it too much with regards to how common it is. But you brought up a really good point, and that is predicting beforehand is one of the critical aspects. And understanding, is that severely hypertrophied LV hypertrophic cardiomyopathy? Is it decades of poorly controlled hypertension? Is it amyloidosis? Are there other diagnoses that we need to be thinking about, not just in the management of putting the valve in, but in terms of the candidacy of that patient and optimizing their outcomes? So I think in general it's rare, but that doesn't mean we don't want to prepare for very rare events.
Mm-hmm. I think you're right. I mean, I think the vast majority of hypotension after TAVR, you got to go through the regimen of what are the common causes: bleeding, perforation, acute AR, all these things that you're dealing with. But I think it's one of those things that after all that is eliminated, because the treatments are very different, then you have to determine what this is. And you have to do all of that within 5 minutes because the patient's crashing on you. My experience has been that it's also very tough to determine if the obstruction, how much is from the valve and how much is from the subvalvular space. And I do think that people need to tease that out ahead of time, as well as look for these other disease states like HCM or amyloid or even sarcoid or other things. So I think, tell us about in your TAVR experience, how do you do that? How do you chase down an obstruction? Do you just rely on the baseline echo, or do you force some provocative maneuvers? And how much do you use the cardiac cath at that point?
Well, I'm so glad you brought that up. Actually, one of the manuscripts that I wrote in fellowship was about diagnosing obstruction in series. And so thinking about having a midcavitary or LV outflow tract obstruction in addition to aortic stenosis. And it's really important to get it right, because sometimes it's not even the valve that's the main issue. And then we're not serving the patient even if they tolerate the valve replacement fine. So I do think it begins obviously with the echocardiogram, but let's go back to basics. I think that provocative maneuvers at the bedside when you're listening with the stethoscope, whether you happen to catch a PVC or you ask them to do a Valsalva, we should really not hear a marked accentuation or an additional murmur of MR if we just have a fixed stenosis. So I think the physical exam is pretty fun, for distinguishing between dynamic and fixed obstruction. But yes, after the echo, then the cath lab remains a very important spot to identify the different hemodynamics of these different perturbations and make sure that we're aiming our therapy for the right thing. And I think it's important to talk about it today, actually, Hari, more than ever before. We just had a new performance measure come out for TAVR, and it says you've got 90 days from the time of diagnosis till you get that valve in. And we have to remind ourselves, not all of the patients referred to us are straightforward severe aortic stenosis.
Mm-hmm. That's an important point I think you just made, because I think that those metrics are because on the one side, if you wait too long, if it is critical AS, these patients do poorly. But on the other hand, if it is mostly HCM, you're doing an inappropriate procedure that might not be required for a few years, and they may get worse. And, we sit on other sides of the aisle, which is I see the patients who get the inappropriate TAVR and have a problem because that's the time they call me. Or I see all these ones that they pull out proactively to have alcohol ablation or some other therapy ahead of time so that I can clear them and say, I don't think this is going to be a problem for the TAVR, and move them forward. That's way it's more anticipatory. But I think I will tell you in my experience, the ones that I pulled out and they have severe AS and they turn out to have severe HCM as well. Once I get rid of the outflow tract obstruction, almost invariably the AS becomes moderate on all subsequent echoes. And so the average time from alcohol in a patient who was put through the regimen for TAVR, taken out of the queue and had an alcohol ablation, the average time to TAVR ends up being 2 to 3 years. Primarily because once I do the HCM alcohol ablation, then I check their echo in a few months, it becomes moderate, then I follow them every 6 months, and it takes a couple of years for them to become severe, and they get the TAVR, and they go through both procedures swimmingly. But it has raised my awareness that some of these pushes to do things quickly may inadvertently push all these patients through. So I am concerned, so that you have to balance the two concerns, and I think part of this podcast is that we understand this, so the HCM docs listening can really look carefully about how much is the HCM contributing. And there's two types of population, right? There's going to be the actual HCM who's longstanding HCM that develops AS, and there's going to be the patients who are de novo AS, and then through the studies they evaluate that there might be an HCM or outflow tract component. So those are looking at the problem two different ways in terms of they come up. The ones with longstanding HCM, we know they have HCM. And then it's easier to sort of figure out when the AS is getting worse because you have serial echoes. The other ones is much harder. What we've done here is I've taken all these patients, and after the echo, I do a cath, and we do a pullback with an end-hole catheter, and I do all my gradients at 3 different locations, both at the apex, in between the valve and the outflow tract subvalvular space, and then again above the valve. And I can kind of localize exactly where the obstruction is, and I can calculate an actual valve area based on the gradient across the actual valve. And usually I can then estimate the percent of outflow tract obstruction versus the percent of AS, and then take it from there. If there's a significant subvalvular problem, then we have options to do alcohol ablation preemptively. So that's kind of how we do it here. And those have all worked out by and large, typically. Now, there's probably a higher risk of pacemaker in those patients. We haven't written that out, but that makes a lot of sense that there probably would be in those patients. So that's kind of what we've done. We may be overkilling it. It's possible that we're overkilling that. But on the other hand, I think at least our surgeons have not wanted to deal with any of these problems post-op. And we haven't had any of these problems post-op when doing it this way. What do you think about that sequence, or do you think it's overkill? And you can tell me what you think, obviously.
Sure. Yeah, it's great to have this discussion among friends, because then we can talk about some of the variability that is inevitable within medicine. And I do think your experience is very unique, and the partnership between your expertise and your colleagues within the Hocum Clinic and the valve team is really important. Whether or not preemptive alcohol septal ablation is necessary in those cases, I wouldn't be able to comment on it. Just to say that it's very rare that people are doing that across the country. And I think that the likelihood of a severe LV outflow tract obstruction is rare. But most people don't have a huge population of true hypertrophs in their patient population like you do. So most of the people that are folks are worried about are older women with a hypertrophied ventricle from hypertension, very small ventricle and a septal bulge. That's not hypertrophic cardiomyopathy. And I do think that the risk of having, severe SAM or LV outflow tract obstruction after TAVR is very, very rare in those patients. And the potential for complications from additional procedures is high. So I think it just speaks to the incredible network that you have developed, being able to have patients referred from hypertrophic cardiomyopathy from all over the country to you. And for those centers that do have a true hypertroph with severe aortic stenosis, I think you are our go-to guy to understand what are the appropriate steps for that. I think with regards to the hemodynamic cath, just to nerd out on that for a second, the way I was trained is we always had to do transeptals to make sure we're at the true apex to be able to compare from two separate catheters on our pullback. And certainly, I think for most TAVR operators, that would be rare to do. But perhaps in those most complex patients that have a combination of a mid and an LV outflow tract gradient in addition to the AS, more complex hemodynamic assessment may be necessary. But I think in general, we're doing less hemodynamics, and we're even doing less coronary angiograms prior to TAVR. So if there was a need for an urgent septal ablation, a lot of times they wouldn't even know the anatomy right at that time, let alone have a protocol for ordering alcohol up from the pharmacy.
No, you're right. Those are the hazards. It's interesting. I've lived through the era where, for a long time, because echo got so good, they said you don't even have to cross the valve to get the gradients. And nowadays, I think we realized with the increasing amount of HCM that there is, that crossing the valve is very helpful nowadays again. So I think we have to always use our judgment about if something smells like a problem, really fully, thoroughly figure it out. And we're in an era now with everybody has heart teams, right? So the heart teams is no excuse to not take a little pause, even within the 90 days, to figure out what the true disease is and to make sure. So I think that's the take home point. Either way, you want to make sure you have good information and you figured it out together, and you've either decided that it's not relevant or that it is relevant, and then you do the needed steps. You want to talk a little bit about amyloid and other things. How frequently are you seeing these other diseases, not just HCM? We know in the literature there's a lot of overlap at that age between the pathologies of aortic calcification and stenosis and amyloid. How has it been clinically relevant to you?
Well, I think about it both clinically and from a research perspective. So I lead the eligibility review committee on one of the trials in moderate aortic stenosis. So I get to see cases from around the world in addition to my own practice. And I do think there is a lot of overlap of some of these other disease conditions now that we've cast a broader net for treatment of aortic stenosis. For so many years, we didn't include a lot of the elderly patients in the treatment algorithm. And now that TAVR is well established as being a very safe and effective therapy, we're seeing, a broader group of patients. So I think that still, I actually want to push back a little bit on the heart team comment, because I think that heart teams are, at times, it can be very beneficial to have a broad group of thinkers and people that are really providing expertise and different opinions. At the same time, we know that a lot of heart teams can fall into a group think model where they're kind of all looking at things the same way. They're all very geared on the therapy that they're treating. And there's a lot of pressure on throughput. And so I'm not sure that the heart team is the answer to what it is we're saying, unless we have truly other experts like you're describing, like a Hokum clinic, and that those members of that heart team are humble to refer out when things just look a little bit different so that we can have that expertise. And I think as the volumes increase and people get busier, maybe we're doing less of that. So I think this podcast is a good one to remind us, not all those patients coming to us have simply severe AS, and we need to be thoughtful about it.
I learned that lesson also in the HCM team, because I think you're right. The teams work best when there are disparate viewpoints about what to do. And so in our heart team, we have heart failure as well. And the heart failure doctors are always thinking about advanced therapies. And what will happen if something goes bad? And or should we just go straight to transplant? Those kinds of things, which is totally not what we were going to the heart team for. We want to do an invasive therapy. And the surgeon, same thing. It really works well when each person has something that they feel it might be better in certain situations. And now we get to figure out as a group what's the best path forward. But you're right. I think part of the structural teams that I've seen, at least at different institutions, they all want to do the same procedure. So then how good of a heart team is that? I know we're being a little controversial now, but it's one of the pitfalls you have to be careful with as the heart team grows.
Yeah, I'm not sure if it's controversial, but really just quality improvement. I think we've had, when we say heart team, it could be many different things. In this case, if we're talking about interventional cardiologists, cardiac surgeons, and sometimes imagers, if they're still included, it depends. It varies, and anesthesia less so now, and heart failure less so. We tend to put all those resources towards mitral and tricuspid because, boy, do we not need all hands on deck to figure out the best way forward there. But I think that it's time for the heart team to evolve in aortic valve disease, and that's what we're talking about today. Like, how can we take something that's worked really, really well and continue to reshape it in the way that reflects the practice that we have?
Yeah, excellent. So I'm going to mention one thing that I think is on people's minds is, there's new medications now for hypertrophic cardiomyopathy too. They have not been tried, of course, in the sort of preemptive phase of how to eliminate these kinds of obstructions or manage the HCM beforehand. But technically, if the patient has actual HCM and there is an obstruction, one can make the argument to treat that with mavacamten, or if mavacamten is approved in the future, treat them with cardiac myosin inhibitor. See how it does for the first 3 months, and then see what the gradient is after that, and make a decision about the aortic valve based on that. I can see that coming. We haven't really done that here yet, and there's obviously the concern that if the output's low from diastolic dysfunction or whatnot, what does mavacamten do in that situation? But if we're talking about obstructive patients, if you think there's a subvalvular obstruction, you could probably make an argument to try that. I haven't done that, but I do think that it's something that people may want to think about. Has that come up at your institution?
What a fun question. When you're thinking about something like severe aortic stenosis, which is a lethal disease, and we have a lot of feeling about being in a hurry, it would be challenging to think about trialing that. Now, we have to remember what you're suggesting is what you told us already. Those patients with severe AS, when I did a septal ablation, didn't have severe AS. They had moderate AS. So, the analogy it brings to mind right away is how much backlash we had when trying to encourage heart teams to start SGLT2 inhibitors in patients that had valvular heart disease and severe diastolic dysfunction. And there was a lot of pushback. Well, it wasn't exactly studied in this population, although moderate AS was not an exclusion, severe valve disease was. But clearly, in my mind, those medications can really help patients with severe diastolic dysfunction either before or after their AVR. And I'm always thinking about, for most patients who come to us for TAVR, it's not an isolated disease. There's so many other things going on with the ventricle. And that's what you're talking about here. How can we optimize outcomes? And whether that's, before, if we're worried about there being an acute obstruction at the time of TAVR, or we're worried about maybe the patient doesn't have severe AS, I think it would be a special patient with a lot of, experts weighing in, particularly when you've got a mean gradient more than 40.
I'm not advising it, but it's a podcast and it's worth discussing because I think people will think about it, and so they should be informed by our discussion. I will also say that mavacamten takes about 2 months to see most of the effect, about 3 months to see a plateau. But in the studies of aficamten so far, it takes about 2 months to see everything. So and probably within 6 weeks you'll know. So even within 90 days, it might be worthwhile trying these medications for 4 to 6 weeks, and you'll see if it's improving and if the valve's getting better or appearing better, and if they're feeling better. You'll know all that in a short amount of time, and that might be something that we could do in the future as the run-up, as a differentiated before an invasive therapy if you're not sure. I could see trying that in a few patients and avoiding some of the invasive therapies and the risk of pacemakers. Certainly, alcohol ablation and myectomy have taken, I think, about a 50% hit nationwide because of these medications, an appropriate hit because patients are doing well for the most part and avoiding invasive therapies. So I'm always looking at where can it expand in terms of making, like you said, making another disease process, easier and more appropriate.
Help me understand, if we had a patient that had a mean gradient of 40, but there was clearly an LV outflow tract gradient that was difficult to differentiate and looked like features of HOCM, and you started them on mavacamten, what would be the side effects that you would be watching for that would be worrisome to stop the medication immediately and think about valve replacement?
Yeah, I think if you think the significant subvalvular obstruction, as the medication kicks in, the output, if anything, should improve. But if you don't think that that's the case, then you might get worse, right? It's not clear what's going to happen. We don't also have strong evidence yet that it improves diastolic dysfunction in the absence of obstruction. So that's a challenge right now to know. So I think you'd have to know that there's subvalvular obstruction. I would say if you cath the patient, you find severe subvalvular provocable gradients and a hyperdynamic LV, probably that's a safe patient to do, especially during the cath. If the cath shows an index over 2. Let's say the index is less than 2, I might be more worried. And I'm just being anecdotal here. I don't really know the answer. But I think if I had a good baseline index and I had a significant subvalvular obstruction, I might try one of these medications first to see if the patient feels better. Remember, these patients actually feel better. And so they'll tell you. It'll be obvious to them if it's working. And then it'll be obvious to us, how much the AS is, because the AS is what's left. And ultimately, these patients end up needing both, is the truth. It's just the timing. Let's spend the rest amount of time on treatment. So let's say we went through this, and we put the TAVR in, and talk us through a patient who would have suicidal LV. You've been there. What happens?
Yes, I think that preparing for any situation where you have an acute LV outflow tract obstruction is really important. And I think where it comes up more often for patients is when we're doing mitral interventions, such as a mitral valve replacement. I still think that it is pretty rare in TAVR, and that the first step, I would say, is to go through your list of all of the other complications. And sometimes they can be a little bit tricky to identify. So, for example, we had a case years ago where a patient actually had an LV perforation from the wire. And this patient had had prior cardiac bypass surgery. And so it was a very focal, isolated pericardial effusion that did lead to some tamponade symptoms. But it was, over 24 to 48 hours. And for many of those patients that have LV outflow tract obstruction, they can be temporized with fluids and other therapies. And in this case, it was hard to tell, I think, from the diagnostic perspective, from an echocardiogram alone, if there was SAM. There's a lot of, how it is.
Yeah, I mean, it's a hypertrophy. It's going to be a small looking underfilled LV. So you're right. I mean, it sounds like you've been burnt the other way, but we're going to have to look at it, all these things. And so I think your teaching point there is, don't just assume it's one thing just because people talk about it. That's correct.
Yes. And the other piece that I think is important that you mentioned is that there has been a marked reduction in the number of physicians that are doing alcohol septal ablation across the country. And even further so, those that are doing more than 2 a year. And so to do that acutely, particularly in a patient for whom you don't even know the coronary anatomy, if you've used your CT scan to rule out proximal disease, which is more and more in TAVR, I think that pursuing invasive therapy quickly does have its risks that are perhaps more than even 5 or 10 years ago, just because of the skill sets. So obviously we start with fluids, we start with beta blockade if possible. We're avoiding things that can exacerbate it, like dobutamine but making the diagnosis is the first step. And I think for most patients, a recent meta-analysis suggested, 65% needed some kind of treatment, but the rest were temporized and then did fine after that. I think for most, there is some time to get everybody together and to figure out. But what are your thoughts about the acute management?
Yeah, so acutely, as you mentioned, first rule out everything else, and things like a small perf that can look just like this or can cause both problems are troubling, and you have to make sure you're not missing all these things. So you do your first treatment, and then you keep investigating to make sure you're barking up the right tree and the patient's getting better. But typically it's fluid, it's recognition, number one, then fluids. Then I will say that we would normally do neosynephrine first. So we add a afterload increaser, vasopressor of neosynephrine to try to tether open the outflow tract, which is probably the safest thing acutely as long as you don't go too high. So 50, then 100, maybe a little bit more, and see how you are with that. Repeat the echoes. Beta blockers, I think, are good too, but the problem is these patients are hypotensive. So this is the challenge. So we usually do the fluids and the neo, and then I would normally say to do something like the Impella device after that, because you need to temporize the situation. Yes, you have a fresh valve in, but by getting past the valve, it's a small LV, so it makes it challenging. We just have to get some blood out. With neo plus that, you might be able to temporize the situation. We've had cases that I've proctored from afar of alcohol ablation. What I've typically done is have them do it acutely with the Impella in, and then keep the Impella in for a few days, because we know that after alcohol ablation for a few days, it might get worse before it gets better because it gets edematous in that location. So it's tricky. And the patients a couple of patients that we've done that on, not here, but I've talked people through at other institutions, patients have done well. But it's very scary, and they're not happy that they had to go through all of that, of course. So that's kind of the treatment right now. Now, the acutely, there's not much data that acutely it really works very well, because as you know, it does create hypokinesis, but then there's some edema. So for the first 72 hours, it might get worse. And then it really gets a benefit around 2 to 3 weeks later when it starts remodeling. And these patients if they're sick, they can't wait that long. But like you said, probably the vast majority can be tackled with just the conservative measures. But they're intensely treated patients and worrisome patients at that time.
Yeah, I think the example that you're sharing where you would do vasopressin followed quickly by Impella, that is a catastrophic presentation, very, very severe. And I think probably for a lot of us, we're all remembering, some signals about the rotor getting caught up in TAVRs and don't put Impellas through. And but the situation you're describing is where you just do what you need to do in order to save the patient's life.
I mean, I suppose you could also just go ECMO and all these things, but these are these patients who, by definition, we've already decided are very high risk patients for the OR and those things. So the other thing is, nowadays, I think shock has also evolved, as you know, that we could tolerate some gradient and see how the patient's doing. If the pressure's okay, check the lactate. Maybe it looks scarier to us, and we want to put an Impella in, but maybe the lactate is clearing, and you can kind of just support them during that time, and then gently add some beta blockers very slowly and transition off the neo. But these are, these take intense heart failure experts or HCM experts, or people who are just good at hemodynamics and very calm for about a week after the procedure, because it's going to take that long. So we could talk about TMVR too, but I think we might want to save that for another day. The topic today was to focus on TAVR because of the frequency of that procedure and the confluence of both of these disease substrates. So any final thoughts about HCM and AS you'd like to bring up, Megan?
I think one of the most important topics with regards to hypertrophic cardiomyopathy and aortic stenosis is that we now, as valvular heart doctors, can really no longer say that we're not focused on lifetime management of that heart. And so really understanding whether the patient is on optimal medical therapy for their hypertrophic cardiomyopathy or their amyloid or their, severe diastolic dysfunction as a result of years of poorly controlled blood pressure. I think those are some of the most important aspects because, we really have to think about for patients that are coming to us, many of them are low surgical risk, which of course doesn't mean they're going to live a long time. It just means they have a low chance of dying at 30 days of surgery. But we are having some patients come to us with longevity. So I think I'm hopeful that this podcast really raises awareness. There are some really acute, exciting things that could happen that we would never want to see, but they're pretty rare. What's more common is really being able to recognize the impact of a ventricle that's unwell when you're treating aortic stenosis and making sure that you're thinking broadly about the diagnoses. That's
great. So I want to thank everybody for joining us. Hopefully our HCM colleagues will be excited about this discussion and be more involved in the structural teams, especially as their patients reach the age where they need aortic valve replacements as well, to be part of that discussion. And I hope that this is probably the only podcast where we have two interventional cardiologists on the HCM Society discussing something. So I think hopefully they'll get a sense that we're also thinking very holistically about our patients in terms of all the medical therapy and trying to get them longevity and quality of life as well. So thank everybody for joining us. And with that, I'll conclude this podcast. And thank you again, Dr. Coylewright.
That was Dr. Srihari Naidu and Dr. Megan Coylewright. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.